Good morning, students. So today we shall going to learn a very important topic, that is drugs for the treatment of diabetes mellitus, which is not only important for your day-to-day practice but also of your theory and practical exam both. And knowledge of diabetes is very important because of its huge burden in India as well as in globally. So how to define diabetes? So it is a metabolic disorder of multiple etiology. It is not merely a presence of hyperglycemia. So remember that diabetes mellitus is a metabolic disorder and it has multiple etiology characterized by chronic hyperglycemia, but also disturbance of this carbohydrate, fat and protein metabolism, and it is due to results from either defect in the insulin secretion or insulin action, or they may be both. So it is a spectrum of disease, and of course, and also it is a very important risk factor for the cardiovascular disease also. And both genetic and environmental factors actually contribute, and main reasons are insufficient insulin secretion due to beta cell defect, reduced responsiveness to insulin, that is a receptor level defect. Insulin receptors may be defective, so insulin cannot work properly, so there is chance of hyperglycemia, and there can be increased glucose production mainly by the liver, and also there can be abnormalities in the fat and protein metabolism. So these are the four reasons of developing these metabolic abnormalities in the diabetes mellitus. Either there can be insufficient insulin secretion, reduced responsiveness to insulin, increased glucose production, and abnormalities in the fat and protein metabolism. So this is the incidence, the prevalence. According to WHO, India had 69.2 million people living with diabetes in 2015, and which is going to increase by 98 million in India by 2030. So what is the criteria for diabetes diagnosis? So in pathology will be discussed again, but diagnosis of diabetes requires HbA1c is more than 6.5%. HbA1c, you know, it is a glycated hemoglobin. A part of, when there is hyperglycemia, a part of hemoglobin which is glycated, that percentage is increased, and overall if it is more than 6.5% of the total hemoglobin, then it is that we can call it a diabetes. But often HbA1c is not able to, patient cannot afford this costly HbA1c test, then we have to rely on fasting and postprandial blood glucose. If fasting blood glucose is more than 126 or PP blood glucose is more than 200 milligram per dl, or if the more actually oral glucose tolerance test, OGTT, 75 gram glucose, and patient is asked to take 75 gram anhydrous glucose, and after 2 hours of consuming that glucose, blood glucose is taken. If it is more than 200 milligram per dl, then it is more reliable report than the postprandial postprandial blood glucose, because often meal quantity of many patients vary. So 75 gram glucose, oral glucose tolerance test, is more standardized form of detecting the postprandial hyperglycemia. Or even random glucose, plasma glucose, if it is more than 200, then it is also indicative of the presence of the diabetes mellitus. Now, what is the normal blood glucose level? In fasting, it is below 100. Up to 100 is the normal level, but if it is more from 101 to 125, then we call it as impaired fasting glucose. So impaired fasting glucose means fasting is more than 100 but less than 126. So up to 100 is normal. When it is 126 or more, then it is diabetes mellitus. Similarly, postprandial blood glucose, if it is less than 140, it is normal, but between 140 to 200, we call it as 140 to 199, we call it as impaired glucose tolerance. And if it is more than 200 or more than 200, then we call it as diabetes mellitus. So fasting limit is up to 100, postprandial limit is up to 140, but this 101 to 125 in the fasting, we call it as impaired fasting glucose, and PP 141 to 199, we call it as impaired glucose tolerance. They are only lifestyle modification and some exercise, diet, and dietary restrictions that can result in prevention of the diabetes mellitus. So, but if it is fasting is more than 126 and PP is more than equal to 200, then we call it as diabetes mellitus. But more confirmatory result is obtained with HbA1c. If it is more than 6.5%, then it is a confirmed case of diabetes mellitus. So unless clinical diagnosis is clear, same test is to be repeated immediately using a new blood sample for confirmation. And if there is two discordant results, suppose fasting is 110, postprandial glucose is 220. So result of diagnostic cut point should be repeated. So even if fasting is 110, but if PP is more than 220, then it is a diabetes mellitus. Similarly, if fasting is more 140, postprandial is 170, then also it is a diabetes mellitus. So any of these value, HbA1c or fasting or postprandial, any of these value, if it is more than the upper limit, then it is a diabetes mellitus. But often fasting and postprandial glucose, if it is high, it should be confirmed with another report. For only mere fasting blood glucose 140 doesn't stamp a patient to diabetes, because that fasting and postprandial blood glucose may vary because of the meal pattern of the patients on the last few days. So HbA1c is the more confirmatory result. So what is the ideal advice to the patient? If fasting is more than 126 or 130, like that, we offer a patient either HbA1c or PP blood glucose. If it is any of them is showing more than the standard cutoff value, then we call it is a diabetes mellitus. So fasting 130, if patient's postprandial comes as 170 or HbA1c comes as 6.1, then we cannot call it as a diabetes mellitus. But fasting 130, HbA1c is 6.8, PP blood glucose 180, then as per the HbA1c value, then we call it as diabetes mellitus. So any two cutoff value along with one of them is HbA1c, will stamp the patient as a diabetes mellitus. So if there are different forms of diabetes mellitus, as I have mentioned, that diabetes can be due to either insulin secretory defect or can be insulin action defect. So type 1 diabetes is due to problem in the secretion. It is due to cell destruction. What is that cell? Beta cell. Beta cell of the islets of Langerhans hands of the pancreas. It is defective, so usually leading to absolute insulin deficiency. So there is almost no insulin present in the body. So patients manifest the diabetes symptoms very early, and it can be due to immune mediated or it can be due to idiopathic. Immune mediated can be confirmed by presence of some autoantibody like anti-insulin antibody, anti-GAD antibody, GAD, that is anti-glutamic acid decarboxylase enzyme, and also anti-islet antibodies. These are the autoantibodies present in the immune mediated type 1 diabetes, but more commonly is idiopathic. Whereas type 2 diabetes is predominantly insulin action defect. That is, it may range from predominantly insulin resistance with relatively insulin deficiency to, and ultimately, if it runs for long course, it is a predominantly insulin secretory defect with insulin resistance. So initially it starts with insulin resistance with some relative insulin deficiency. That means relative insulin deficiency means insulin level is normal initially, but it cannot act properly. That's why there is resistance, and that's why there is hyperglycemia. But ultimately, as the disease progresses, there is also secretory defect as well as insulin resistance. It can be other specific type of diabetes, I shall discuss later, and different disease of pancreas, different drugs can cause diabetes, and gestational diabetes mellitus. So these are the four major forms of the diabetes mellitus. First one is type 1. First, it is a secretory defect. Type 2 is the mainly insulin resistance. Type 3, specific diabetes, and type 4 is gestational diabetes mellitus. That means the diabetes which is manifested after pregnancy. Okay. So what are the specific types of diabetes? It can be genetic defects of beta cell function. It is also all will be discussed in the pathology class in detail. Genetic defects in insulin action, diseases of the exocrine pancreas like pancreatitis, patients having pancreatectomy, cystic fibrosis, hemochromatosis, fibrocalculous pancreatopathy, different endocrinopathies like very common is Cushing syndrome, acromegaly, pheochromocytoma, hyperthyroidism, somatostatinoma. They can cause this diabetes. Some drugs are chemical induced. Chemical is one of the chemical is Vacor, and infections like rubella, cytomegalovirus, congenital form, they can cause specific type of diabetes. And these are the different drugs. So these are the specific types of diabetes. Mainly you have to know the endocrinopathies and the disease of the exocrine pancreas, and drug or chemical induced. So what are the drugs responsible? So drugs which alter the glucose level, there is a long list. Most importantly, we have to know the glucocorticoid, antipsychotic, we know that. Antipsychotic, atypical antipsychotic like olanzapine, clozapine, risperidone, they can cause this hyperglycemia. Protease inhibitor, we all know that protease inhibitor like indinavir, lopinavir, ritonavir, they can cause hyperglycemia. Beta adrenergic agonist, diuretics, so you know very well that thiazide loop diuretics, they can cause this metabolic abnormality including hyperglycemia. And other less common examples are diazoxide, nicotinic acid, interferons, thyroid hormones. So most importantly, we have to know glucocorticoids, atypical antipsychotic, diuretics, and protease inhibitors. Hypoglycemia can be caused by different drugs like theophylline, ethanol salicylate, beta blockers, etc., and also NSAIDs. So characteristic of type 1 and type 2 diabetes mellitus, onset is usually early in the type 1, but that is not a very clear cut. Often type 2 can be manifested in the age like 18 years. So it is not a very important marker, but if it is at least appears below 12 years or 10 years, then it is almost a type 1. And type of onset, it is type 1 is abrupt and type 2 is gradual. And nutritional status, it is type 1 patients usually thin. They manifest the typical symptoms of the diabetes like polyuria, polyphagia, polydipsia, and associated with there is weight loss. But type 2 is mostly obese patient or overweight patient. Clinical symptoms, type 2 is often asymptomatic, and that's why it is often detected late. But type 1, it is abrupt onset, and there is presence of these three classical symptoms: polydipsia, polyphagia, polyuria, and associated with weight loss. Ketosis, it is frequent in type 1, less common in type 2, but it may present. Endogenous insulin, as type 1 is insulin secretory defect, so insulin level is very negligible in type 1, almost absent, and type 2, insulin is present but relatively ineffective. And associated abnormalities like hypercholesterolemia is frequent in type 1, and most importantly, therapy as a concern of the therapy, type 1, as there is insulin secretory defect, we have to replenish the insulin. So insulin therapy is must in type 1, but in type 2, insulin therapy is needed in some cases, not in all cases. There the mainstay of therapy is oral drug. Okay, so insulin is required only in 20 to 30% case of the patients of the type 2. So these are the major differences of type 1 and type 2. We have to know the defect, otherwise we cannot plan the therapy. So how to detect type 1 and type 2, I shall discuss after we discuss the insulin. Okay, so from this list you can understand that if we measure the serum insulin, then in type 1 it is very low or absent, and type 2 insulin level is normal. And also insulin, along with insulin there is another agent is secreted, that is called C-peptide, and C-peptide is also assayed, can be assayed. C-peptide level is also normal in the type 2, but it is absent in type 1, and along with that, in immune mediated type 1 diabetes, there can be presence of some autoantibody like anti-islet, anti-GAD, anti-insulin antibodies. Okay, but in type 2 these are absent. Okay, so hypoglycemic drug should not be used in type 1 because it will it will not have any effect. You have to give insulin. In type 2, oral drugs are the mainstay of the therapy. Okay. Now let's discuss some physiology of the glucose homeostasis. So physiology, in fasting state, glucose is supplied primarily from the liver, and with fasting, plasma insulin levels are low and plasma glucagon is elevated. So insulin level is low in fasting, glucagon is elevated, which this glucagon is actually responsible for the glucose production from the liver, and there is increased glycogenolysis and gluconeogenesis. So glycogen enzymes for the glycogenolysis, enzymes for the gluconeogenesis, these are stimulated by the glucagon. So low insulin also increases the lipolysis. Fatty acids are released more from the adipose tissue. So when in the fasting there is more activation of the glucagon, less activation of the insulin, and this low insulin causes increased lipolysis, and there is more fatty acids delivered to the liver, and this fatty acid is used as a substrate for the neoglucogenesis. And most tissues oxidize primarily fatty acid during fasting, sparing glucose for the use by the CNS. So glucose is to be used by the CNS, and so that's why more tissue oxidize primarily fatty acids during fasting. So due to this excess fatty acid metabolism during fasting, there is chance of ketoacidosis from ketosis during the fasting state. So this is the in fasting state, there is relative excess in glucagon release, and this glucagon will cause increased glucose delivery to the brain by excess production of the glucose in the liver by the neoglucogenesis and glycogenolysis, and from the brain there is a signal which causes more glucose delivery to the skeletal muscle also. Okay. But in prandial state, what happens? During feeding, nutrient absorption causes an increase in the plasma glucose. So in the fasting state, there is more activation of the glucagon, but when patient takes we take meal, there is insulin release. Along with insulin, there is another agent that is secreted from the intestine that is called incretins. So incretins are released from the gut and some neurostimuli that promote insulin secretion. And what is the effect? Sorry. Liver, skeletal muscle, and adipose tissue actively take up glucose by the insulin action. So insulin helps in the clearance of the blood glucose from blood to the tissue. So they cause increased uptake of the glucose in the tissues. What are the major tissues? Liver, skeletal muscle, and adipose tissue. They actively take up the glucose by the insulin action. And hepatic glucose production and lipolysis are inhibited. So in fasting state, these are stimulated, lipolysis and hepatic glucose production. So when patient eats, then lipolysis is also inhibited and hepatic glucose production also inhibited. So total body glucose oxidation increases and the brain senses plasma glucose concentration and provides regulatory inputs. So these are the fasting state when insulin takes upper hand and there is more uptake of the glucose into the skeletal muscle, into the adipose tissue, and also into the liver due to action of the insulin. And insulin is released mainly by the stimulus of the incretins that is released from the gut. So when patient eats, the intestine sense that and there is liberation of the incretins. This incretin helps in more insulin release when patient takes meal. So this is the pancreatic islet physiology. So insulin, beta cells secrete insulin, and this is when there is high blood glucose. Just after taking meal, insulin release is increased, and the result is glucose uptake into the tissue. Glucagon, on the other hand, is secreted by the alpha cell when blood glucose is low, and glucagon effect is just opposite to the insulin. Insulin helps in the more uptake of the glucose into the tissue, whereas glucagon helps in the more production of the glucose into the liver, and glucose is released from the tissues back into the blood. So insulin causes shift of the glucose from blood to the tissue. Glucagon causes shift of the glucose from tissue to the blood. So insulin and glucagon is a physiological antagonist, you know that. So this is the picture of fasting state, and this is the high blood glucose. What is the effect? Gastrointestinal hormone secretion is increased. One of them is GIP, glucose dependent intestinal polypeptide, and islet of Langerhans, alpha cell liberates glucagon, beta cell liberates insulin, and when there is increased effect of the insulin, muscle, there is insulin induces glycogen synthesis, and all tissue insulin increases transfer of the glucose and amino acid into cells. So insulin increases the glucose uptake by all the tissues, and kidney tubules also insulin increases the absorption of the glucose from the filtrate. And in liver, what is the effect? Glucagon induces glycogenolysis and release of the glucose into the blood, but insulin has the opposite effect. Insulin suppresses the glycogenolysis. So liver is a very important organ. In fasting state, under the influence of the glucagon, there is more glycogenolysis and neoglucogenesis, so there is more production of the glucose. Whereas under fed, when patient is fed in prandial state, insulin takes the upper hand and they inhibit the glycogenolysis. Also, insulin helps in the uptake of the glucose from the blood into the different tissues, including muscle and adipose tissue, and also kidney. They help in the increase the absorption of the glucose from the filtrate. So this insulin secretion, you know this from the physiology. So the primary molecule is pre-proinsulin, which is a 110 amino acid peptide. It consists of a signal peptide, B chain, C peptide, and A chain. And this signal peptide, that SP, is cleaved and disulfide bond is formed as proinsulin folds. So this is the straight molecule, that is the pre-proinsulin. After that, when the SP, signal peptide, 24 amino acid is cleaved, so 110 minus 24, it is 86. So pre-proinsulin is 110 amino acids, proinsulin is 86 amino acid. It contains A chain and B chain of insulin as well as cyclic C peptide. So 2 prohormone convertase PC1 and PC2 cleave proinsulin into insulin, C-peptide and 2 dipeptides. So A, B, C, A chain, B chain and C peptide. Okay. So this is the 86 amino acid structure proinsulin. It is formed after cleavage of the SP, signal peptide. And after that, pro-converting PC1 and PC2, insulin and C-peptide are stored in the granules and co-secreted in the equimolar quantity. So PC1 cleaves that one side and PC2 cleaves one side. This generates insulin and C-peptide. So insulin A and B chain is joined and C-peptide is liberated. So there is equimolar release of the insulin as well as C-peptide. That's why insulin assay is often difficult, and that's why C-peptide assay is done to detect what is the type of the diabetes. If it is C-peptide is less, we can, or almost absent, we can call that patient is suffering from the type 1 diabetes mellitus. But if C-peptide is normal, then it is a type 2 diabetes mellitus, because insulin secretion is normal in type 2. Next, regulation of the insulin secretion from the pancreatic beta cell. So how insulin secretion is regulated in our body? So normally the pancreatic beta cell in a resting state is hyperpolarized. Okay, and glucose entering via the GLUT transporter is metabolizes and elevates the cellular ATP. So glucose is entered by some transporter that is called GLUT, GLUT. There are different types of the GLUT depending on the different tissues, but basically, so glucose is when it is transported inside the cell, GLUT, they are converted into glucose 6-phosphate by the glucokinase enzyme, and after that there is metabolism as per the glycolysis and Krebs cycle, and there is generation of the ATP. And so glucose entering into the cell by the GLUT, there is formation of the ATP as glucose is converted into different metabolites by the Krebs cycle, and there is inhibits this ATP generation actually inhibits the potassium entry through the potassium sensitive ATP channel. So there is a potassium sensitive ATP channel in the pancreatic beta cell. Okay, so glucose enters by the GLUT transporter. There is then glucokinase enzyme is the first step that converts glucose to glucose 6-phosphate, and afterwards different reactions happens and there is generation of some ATP. This ATP will inhibit the potassium sensitive ATP channel, and this decreased potassium conductance results in depolarization of the cell. So normally it is hyperpolarized, but when there is ATP generation due to glucose entry, there is inhibition of the potassium sensitive ATP channel, there is decreased potassium conductance, and this indirectly will depolarize the cell, and after that there is liberation of the there is increased influx of the calcium. So potassium sensitive ATP channel is inhibited and there is depolarization of the cell. In this depolarized state there is more influx of the calcium, and after that influx of the calcium you see there is a stored insulin. So stored insulin are exocytosed. So incretins also acting via the G protein coupled receptor, they increase the cyclic GMP and they also help in the release of the stored insulin from the pancreatic beta cell. So this is the effect of the glucose entry into the pancreatic beta cell. So when there is increased glucose, there is more ATP generation. That means potassium channels are inhibited, more cell is depolarized, there is more calcium influx, and there is more exocytosis of the stored insulin from the pancreatic beta cell. So this is the effect of the regulation of the insulin secretion from the pancreatic beta cell. So leads to calcium dependent exocytosis of the stored insulin. And here you see there is a receptor called SUR1. So SUR1 stands for sulfonylurea receptor, and there is sulfonylurea receptor. It is an example of orphan receptor. That means receptor is present, but normally its ligand is absent. That means sulfonylurea is a group of drug which, if it is given from externally, then sulfonylurea receptor are stimulated and the result is same. So the result is inhibition of this potassium channel, and inhibition of the potassium channel will cause more entry of the calcium, and ultimately there is more release of the insulin due to exocytosis. So sulfonylurea group of drug acts by the similar mechanism of insulin. Insulin acts in the same manner as glucose actually. So glucose also helps in the insulin release. Sulfonylurea also helps in the insulin release, but sulfonylurea acts by different receptor, SUR1, that is a warfarin receptor, whose ligand is absent normally in our body, but we give it from externally so that the drug binds to the SUR1 receptor, inhibits the potassium channel, and that causes increased calcium influx and exocytosis of the insulin. Okay, so this is the mechanism of insulin, how glucose helps in the insulin release. So these are the different glucose transporter: GLUT1, GLUT2, GLUT3, GLUT4, and remember this GLUT2, which is present predominantly in the liver and pancreas. So pancreas, what is the type of GLUT in the pancreas? It is a very common MCQ. It is GLUT2. Whereas in skeletal muscle adipose tissue, it is GLUT4. So liver, pancreas, you remember GLUT2, but skeletal muscle adipose tissue, these are GLUT4. Whereas brain contains GLUT3. Okay. So GLUT2, GLUT4, it is often confused. So GLUT2 is pancreas and liver, and GLUT4 adipose tissue and skeletal muscle. How autonomic nervous system is important? So adrenergic alpha-2 receptor activation decreases the insulin release. That is the predominant effect of the ANS by inhibiting the beta cell adrenal cyclase. So adrenergic alpha-2 receptor activation decreases the insulin release. That is the predominant effect. That means when that can happen. So when you are giving beta blocker, then there is more alpha activation, and that can cause decreased insulin release. So that's why beta blockers are contraindicated, relatively contraindicated in the diabetes mellitus, because that can cause decreased insulin release because of the predominantly alpha-2 activation. Whereas what is the effect of the beta-2 receptor? The adrenergic beta-2 stimulation increases the insulin release. So beta agonists tend to increase the insulin release, but that is less prominent. Okay. So alpha-2 prevents the insulin release, and beta-2 stimulates the insulin release, but alpha-2 action is predominant. Whereas what is the effect of the cholinergic? Muscarinic activation by the acetylcholine receptor through the IP3 DAG pathway, and that cause increased calcium in the beta cell, that cause more insulin release. So that is also less predominant issue. So acetylcholine also helps in the insulin release to some extent, but remember, alpha-2 stimulation decreases insulin release, whereas beta-2 stimulation, they help in the insulin release. Now insulin action, you have read it in physiology, but once again we have to recapitulate it. So insulin signaling is critical for the promoting the uptake, use and storage of the major nutrients. Glucose, not only glucose, they also help in the uptake and storage of the different proteins and lipids also. So glucose, lipids, amino acids, all of them are the cellular uptake of all these agents are increased by the insulin. And what is the effect? They stimulate the glycogenesis, they stimulate the lipogenesis, and insulin also stimulates the protein synthesis. So insulin is an anabolic hormone. It causes stimulation of the glycogenesis, it causes stimulation of the lipogenesis as well as protein synthesis. Whereas it inhibits what they inhibit? They inhibit the glycogenolysis, they inhibit the neoglucogenesis, they inhibit the lipolysis. So it stimulates transport of the substrates and ions into the cell. It regulates the action of the specific enzymes. So glycogenesis, enzymes of the glycogenesis, enzymes of the lipogenesis, they are stimulated by the insulin, whereas enzymes for the glycogenolysis, enzymes for the lipolysis, enzymes for the neoglucogenesis, they are all inhibited by the insulin. So that is done by controlling of the gene transcription and the mRNA translation. So this inhibition of the enzyme and stimulation of some enzymes on the defined metabolic pathway, that is done by as the insulin also control the gene transcription and the mRNA translation. So this is the mechanism action of the insulin. So the insulin receptor, you know from the general pharmacology, it is a transmembrane receptor having intrinsic tyrosine kinase activity. So when there is insulin binds to the receptor dimerizes. So there is dimer of the receptor. One insulin receptor is composed of this alpha and beta subunit. Beta subunit is responsible for the binding action, alpha subunit on which insulin binds. Okay. So alpha subunit and beta subunit, when insulin binds to the receptor, there is dimerization of the receptor, and this dimerized receptor, there is internalization of the receptor, dimerized receptor, and after that there is involvement of some protein that is called IRS, that is called insulin receptor substrate. this is phosphorylated. Why there is phosphorylation? Because when there is dimer formation, there is increased tyrosine kinase activity that causes phosphorylation of the receptor as well as phosphorylation of this insulin receptor substrate protein IRS, and that leads to different downstream events like involvement of the second messenger PIP3, phosphorylation cascade, and there is activation and inhibition of the enzymes. Also, there is stimulation of the MAP kinase, and that leads to increased transcription of different proteins are stimulated, and also there is cellular proliferation and differentiation also enhanced by the insulin. So that's due to this MAP kinase activity, there is more cellular proliferation, more differentiation, and that often leads to, and as insulin is an anabolic hormone, so they tend to store more glucose, they tend to store more proteins and fats in the cell. So that's why, and also due to the cellular proliferation effect, there is weight gain with insulin, and this is not due to its receptor direct activation or inhibition of the enzyme, but it is mostly responsible by this MAP kinase stimulation. Okay, and when there is glucose is entered, there is more one of the effect of the insulin is that when there is stimulation of the insulin, this protein they also causes translocation of the glut transporter from cytoplasm into the membrane, so that more glucose can be uptaken. Okay, so that is the net effect of the insulin. Insulin binding activates the intrinsic tyrosine kinase activity of the receptor dimer. So there is receptor is dimerized, and after the dimer formation, there is activation of the intrinsic tyrosine kinase activity, and this tyrosine phosphorylation of the receptor subunits, and a small number of insulin receptor substrate proteins. So tyrosine phosphorylation causes not only phosphorylation of the receptor, but also phosphorylation of the insulin receptor substrate protein, that is called IRS. There is and one of the effect of the insulin is that they can influence the transcription, and there is also translocation of the GLUT4 glucose transporter from the intercellular vesicles to the plasma membrane. Not only GLUT4, also GLUT2 present in the islets of pancreas, also GLUT2 present in the liver, GLUT4 present in the adipose tissue and skeletal muscle mainly. So there is translocation of the GLUT4 glucose transporter from the intercellular vesicles to the plasma membrane, so that more glucose can be uptaken by the cell. And this is the net effect of the insulin, and insulin stimulates the plasma membrane, sodium potassium ATPase also, and also insulin by stimulation of this MAP kinase, they cause enhanced transcription and cellular proliferation and differentiation. So this is the effect of the insulin. So mechanism of action of insulin, if it is asked, then you have to take this receptor dimerization, intrinsic tyrosine kinase activity, phosphorylation of the receptor, phosphorylation of the IRS, and there is then second messenger activity PIP3, phosphorylation cascade, and activation or inhibition of the different enzymes. Activation of the which enzymes? Activation of the enzymes which causes glycogenesis, activation of the lipogenesis, and inhibition of the glycogenolysis, neoglucogenesis, and inhibition of the lipolysis. Okay, so these are the effect of the insulin. Next, what is insulin resistance? Insulin resistance is defined as failure of normal amounts of the insulin to elicit the expected response. So this is the defect in the which is seen mostly in the type 2 diabetes mellitus patient. So in type 1 there is insulin secretory defect, but in type 2 there is insulin resistance, and which is defined as failure of the normal amounts of the insulin to elicit the expected response. And there is inherent variability of insulin sensitivity among cells, tissues, and individuals. The insulin sensitivity is affected by the age, body weight, physical activity levels, illness, and medications. So persons with type 2 diabetes or glucose intolerance have reduced response to insulin. So in type 2, insulin level is normal, C-peptide is also normal because they are released in the equimolar concentration from the beta cells, but the defect is in the cellular level. That means insulin cannot act properly because of the receptor level defect. So insulin resistance in muscle and fat, what is the effect? There is decreased transport of the glucose from the circulation. So insulin helps in the shift of the glucose from the blood to the cell, that is impaired. So there is decreased transport of the glucose from the circulation, decreased uptake by the muscle and fat. There is increased hepatic glucose production due to, as insulin cannot act properly, so there is more neoglucogenesis, glycogenesis in the liver, so there is more hepatic glucose production. Insulin resistant adipocytes also cause increased lipolysis and release of the fatty acid into the circulation, and that contributes to the insulin resistance in liver and muscle also. There is, as there is more fatty acids, there is accumulation of the fatty acids in the liver, there is chance of hepatic steatosis and dyslipidemia. So this is the effect of the insulin deficiency or resistance actually. So their insulin level is normal, but it cannot act properly. So we have discussed insulin secretory defect and insulin resistance, but type 2 diabetes is not only these two mechanisms. There is ominous octet. You have to remember this, because often we will discuss the drugs which act by all modifying these 8 effects. So not all 8 effects, but some drugs will block some effects. That's why we have to know what are the 8 pathways. So there is one of them is, so if you start from the left, there is one is increased glucagon secretion. So that is a defect in the diabetes. So often insulin is normal, but excess glucagon effect can cause hyperglycemia. There is impaired insulin secretion, which is known as it is a type 1. Decrease incretin effect. So incretin is a very important molecule which is released when we take meal. The intestine sends that meal and they liberate the incretins, and incretins actually help in the more release of the insulin. We have seen in the picture of the insulin release, incretin had their receptor present in the beta cell also, and those are G-protein coupled receptor, and incretin stimulates the release of the more insulin. So if there is decrease in incretin effect, there will be decreased insulin release. Increased lipolysis can also enhance the insulin resistance. Increased glucose reabsorption from the kidney, that also helps increase the hyperglycemia. So one of the new drugs can inhibit this pathway. So increased glucose reabsorption is also a reason of hyperglycemia present in the type 2 diabetes. Decreased glucose uptake. Decreased glucose uptake as seen in the skeletal muscle, liver, as well as adipose tissue, that is also a defect in insulin resistance that can cause hyperglycemia also. And neurotransmitter dysfunction often leads to this decrease in incretin effect due to hyperglycemia. So when there is neurotransmitter defect dysfunction, means when there is more activation of the alpha receptors, which is at alpha adrenergic receptor, that will cause decreased insulin release, and that can cause hyperglycemia. And increased HGP. HGP means hepatic glucose production. So these are the reasons which can cause hyperglycemia, and different drugs can modify different effects. So we have to remember all these 8 effects which can cause hyperglycemia in the type 2 diabetes, in the diabetes mellitus. So these are the impaired insulin secretion, increased glucagon production, increased hepatic glucose output, decreased incretin, increased lipolysis, increased glucose reabsorption, decreased glucose uptake, and neurotransmitter dysfunction. So these are the 8 effects. Neurotransmitter defects also, dysfunction can also, we can call it a central effect. Often there is a central stimuli which can cause impair the satiety of our body, that will influence the food intake of an individual, that can also influence the hyperglycemia. So these are the ominous octet. We have to remember this. Actually it is responsible for the development of the hyperglycemia, mostly in the type 2 diabetes mellitus. So what are the goals of the therapy? First, we have to manage the glycemic control by diet, lifestyle, exercise, medication, and treatment of associated conditions. So I have mentioned that diabetes mellitus is a metabolic disorder, not merely presence of the hyperglycemia. So this presence of these metabolic disorders often leads to development of the other problems like dyslipidemia, like hypertension, obesity, and most importantly cardiovascular disease. So diabetes is a very, very important risk factor. Actually, presence of diabetes and presence of cardiovascular disease, they are all, so suppose a patient having non-diabetic patient having an event of myocardial infarction, their risk in developing the future cardiovascular problem, and a diabetic patient without myocardial infarction, their risk in future diabetes mellitus problem, they are almost similar. So that's why diabetes mellitus patients are called this is development of diabetes. Actually, this is a cardiovascular disease equivalent. So the CV disease is equivalent. That's why cardiovascular diabetes is nowadays it is called as actually cardiovascular problem. So CV events are much more high in the diabetes mellitus because of this different metabolic abnormality. And that's why you have to screen for manage of complications. So there are multiple problems like retinopathy, neuropathy, nephropathy, cardiovascular disease, also other problems like there is problem in the foot, there is problem in the skin infections. So different manifestations problems are there, but if hyperglycemia is well managed, then all can be prevented or treated. So non-pharmacological aspects, we have to ensure that patient is has been advised appropriate lifestyle modification advice. So patient should be educated about the nutrition, exercise and medication. Medical nutrition therapy is the diet that coordinates calorie intake and other aspects of the diabetes therapy, such as pharmacological agents and exercise. In type 1 diabetes, matching caloric intake and insulin dosing is very important. Otherwise, there is chance of hypoglycemia. So in type 2 diabetes, diet is directed at weight loss. So in type 1, patient is already having less body weight. So there, weight loss is not the predominant role. We have to rather give good caloric intake so that insulin can act properly and will not cause hypoglycemia in them. So matching caloric intake and insulin dosing is very important in type 1. For in type 2, diet is directed at weight loss and reduction of the blood pressure and other abnormalities like cholesterol problems, atherosclerosis risk should be minimized. And bariatric surgery is another option, and it has been found that actually bariatric surgery, if it is done early in patients having where properly indicated. So when it is indicated, so if it is BMI more than 35 with comorbidity or BMI more than 40 without comorbidity, if diabetes is present in them, bariatric surgery can reverse the diabetes mellitus also, or at least will have a very good control of the diabetes patients on those patients. Okay, so bariatric surgery is indicated if it is BMI is more than 35 with comorbidity. Comorbidity means hypertension, dyslipidemia, or other ischemic heart disease, myocardial infarction, etc. And if BMI more than 40 without any comorbidity, then also bariatric surgery is indicated. Now we have to know about the discovery of the insulin. So insulin, we have to learn it in detail. It is the mainstay of therapy of the type 1 as well as a very important weapon in type 2 diabetes mellitus also. So how insulin was discovered? We have to know in short. So in 1889 almost, it was seen that pancreas, removal of pancreas is actually detrimental for the health of some animals. So removal of the pancreas will cause will have the effects of the hyperglycemia, and these effects of hyperglycemia will reduce the lifespan of the different animals significantly. And this research continued, and there was no treatment was available. Only treatment of diabetes mellitus, if it is present, that is presence of the glycosuria in the excess glucose in the blood. Physicians only prescribe very restricted calorie intake, and this restricted calorie intake actually cause more starvation in the patient. So there is no only carbohydrate apart from carbohydrate restriction, there was no treatment, and the research was continued, and it was thought that some agents from the pancreas is actually responsible for protection of the diabetes. But when pancreas is removed, probably that support is lost. That's why there is chronic hyperglycemia in those patients. So with progress of this discovery, Dr. Banting, he was an orthopedic surgeon. He, along with his assistant, actually he was a medical student, second year medical student like you, Dr. Best. So Banting, along with Best, so Banting just learned how to remove the pancreas from a dog, and after that he made that one extract from that removed pancreas and injected that extract into another dog who is also already suffering from the symptoms of the diabetes mellitus. Okay, so pancreatic extract removed from a dog that was injected into a already diabetic dog who is also already suffering from the hyperglycemia. That actually they saw that helped in the prolongation of the lifespan of the dog, and it has been found that almost 70 days dog was alive with that extract, and the dog died only when that extract was not available anymore. So that's thus the research on the diabetes was get a new turning point, that pancreatic extract probably helped in the prolonging of the lifespan of the diabetic patients, and that's why thus Banting and West wanted to carry out the research, wanted to progress with the research, but they should, their colleagues or the medical, their colleagues actually, or the other scientists were not so much supportive to their works. They were also all skeptical about their discovery, and that's why they approached to MacLeod. This is a professor of the physiology. So MacLeod at last agreed with their research, and MacLeod provided his lab to for the research activity. So Banting and Best were progressing with the research. MacLeod provided the lab, and Collip, another scientist, James Collip, Collip helped in the purification of the pancreatic extracts, because that's unless it is purified, we cannot they cannot made possible to produce in the large amount also, and also there is chance of some antigenic reaction. So Banting Best helped in the actually made the research. Collip helped in the purification of the insulin pancreatic extract, and MacLeod only provided his lab for their research activity. And after that, in 1922 itself, so 1921 they made this discovery that pancreatic extract can prolong the lifespan of a dog, in a diabetic dog, and in 1922 itself they injected that pancreatic extract or insulin into a human. His name was Leonard Thompson. He was a type 1 diabetic patient. He was only, so when in 1922 he was 14 years of age. So in 14 years of age he was given that insulin. So died from diabetes. He was the first human to get the extract in January 1922. So you will find his name in different quiz competition. Leonard Thompson is the first receiver of the insulin in 1922, and look, he received it in 14 years. So insulin helped in the prolonging his life for 13 years. So he survived until the age of 27. So that is a major improvement in the discovery of the insulin, in the treatment of the diabetes. So this pancreatic extract or the insulin helped in the prolongation of the life of that of this baby, Leonard Thompson. Okay. So later Sanger, he discovered the insulin structure by isolating it, and he also developed Nobel Prize. So due to this discovery, in 1922, MacLeod and Banting was offered Nobel Prize. MacLeod actually helped, only provided his lab. Actually, his contribution was just to agreeing with the research, and Banting has the major idea, but Best also has done a major work in the research also. So Banting shared his prize with Best, and MacLeod shared his prize with Collip. So there are two Nobel Prize. Banting and Best got one, and MacLeod and Collip received one another. So the two Nobel Prizes were shared between Banting and Best and MacLeod and Collip. And Sanger, later, due to his insulin structure, he received the Nobel Prize separately. So this is the history of the insulin, and insulin is the mainstay of therapy of virtually all type 1 and many type 2 diabetes patients, and it is administered, route of administration is very important. So insulin is a peptide, so we cannot give it in orally, because that will be destroyed by the gastric juice, and it is that's why it is administered intravenously or subcutaneously. And so long-term treatment relies on the subcutaneous injection, and subcutaneous administration of insulin differs from physiological secretion of insulin. So subcutaneous insulin, actually it is not so much physiological. So physiological insulin, there is sharp peak after meal and there is rapid fall. So when we eat insulin, there is a rapid peak and sharp fall. Just they control the postprandial hyperglycemia. But when this peak is defective, then there is chance of hyperglycemia, postprandial hyperglycemia, because glucose is not properly uptaken by the cell. So in type 2 diabetes mellitus, when there, or type 1 diabetes mellitus, when there is insulin secretory defect, then there is no such peak, and we have to give the insulin from outside that is delivered in the subcutaneous tissue, and this subcutaneous insulin will not have this rapid rise and sharp fall as manifested by the physiological insulin. That's why there is some difference, because subcutaneous tissue insulin
These absorption kinetics do not reproduce the rapid and decline of the endogenous insulin in response to glucose following IV or oral administration. So injected insulin is delivered into the peripheral circulation instead of the portal circulation. So when we in actually physiological insulin, it is delivered into the portal circulation, whereas subcutaneous insulin is delivered into this peripheral circulation. So that's why there is some difference, but we have to give it in the subcutaneous route. We cannot give in directly into the portal circulation. Okay. So insulin, as it is injected, need to be that's why there is often a compliance issue. Patient on the name of the insulin, they often do not agree that this injectable therapy that is painful. That is also a wrong notion actually. It is not, the newer pains are not so much painful. So it is just less painful than the antibiotic also. But this injectable therapy is often a hindrance to insulin intake. That's why different forms of the other routes have been proposed. One of them is inhaled insulin. So inhalable insulin is a powder form of insulin delivered with a nebulizer into the lungs where it is absorbed. And the name was Afrezza. It is a monomeric inhaled insulin developed by mankind, approved by the FDA in 2014. But it is unlikely to be cost effective. Though it is effective, but it is very costly. That's why it is not so much popular now. So we have to rely on the subcutaneous insulin mainly, but it can be given intravenously in some emergency situations, like when patient is in diabetic ketoacidosis, when blood glucose is very high, along with some manifestation of the ketosis, or some states when there is severe hyperosmolarity in the patient, then we have to give the insulin in the IV route. But otherwise, for daily intake, it is to be given by the subcutaneous route. Don't give it even by the IM route also. So IV or in emergency, and subcutaneous in daily when it is routine therapy. That is the route of administration of the insulin. So insulin preparation is a chemistry. So shortly after discovery in 1921, patients were treated with mainly insulin preparations prepared from either from pork or cow. So porcine or bovine pancreatic extracts were used. With the advent of the human insulin, beef and pork insulin are no longer produced. So human insulin, that is generated by produced by the recombinant human DNA technology, that came in market in the almost 1980s. After that, porcine and bovine insulin are not used. Porcine and bovine insulin, they are causing different allergic reactions because of the antigenic nature. And human insulin produced by the recombinant DNA technology is soluble in the aqueous solution. So most preparations are supplied at neutral pH, which improves stability and permits short-term storage at a room temperature. And dose and concentration of clinical insulin are expressed in the international unit. So just like other heparin, penicillin, insulin dose is also expressed in unit, not in milligram or gram. So concentration of hormone was standardized by the bioassay. What is 1 unit of insulin? 1 unit of insulin is defined as the amount required to reduce the blood glucose concentration in a fasting rabbit to 45 milligram per dl. So that is the 1 unit of the insulin. So properties of insulin preparations. What are the properties? There are what are the types of insulin? These can be short acting and long acting. There were previously another classification was there that was intermediate acting, but nowadays it is short acting and long acting. What are the short acting insulin? Insulin aspart, insulin lispro, insulin regular, and insulin glulysin. Regular insulin actually this human insulin, and long acting insulin is determined glargine NPH. So aspart, glulysin, lispro, and determined glargine, we call them as insulin analogs. That means their structure is almost same, but not totally same like human insulin. But regular insulin and NPH insulin, they are structurally same with the human insulin. That's why they are not analogs. They are insulin, but analog insulin means there is some structural modification from the normal human insulin to enhance their pharmacokinetic effect. Okay, so this is the short-acting insulin, aspart, glulysin, lispro regular, and long-acting is insulin determined glargine NPH. And also there is a newer addition in the long-acting insulin that is called insulin degludec. So look here, onset of action, short-acting, it is for the aspart, glulysin, lispro is very rapid within 15 minutes, 25.25 hours means within 15 minutes there is onset, and also they reach peak early within half an hour to 1.5 hours, and effective duration is 3 to 4 hours. Whereas regular insulin, it is little bit slower. effective duration is 4 to 6 hours. So actually, to mimic the physiological insulin, we want that rapid onset and brief duration of action. So rapid onset means that will take care of the postprandial hyperglycemia more. So there will be more reduction of the postprandial hyperglycemia, as well as effective duration. If it is less, then that will reduce the chance of the hypoglycemia late. So when there is no meal, if insulin then acts also, then there is a chance of hypoglycemia. That's why brief duration of action of the short-acting insulin is also needed to prevent hypoglycemia. As regular insulin have little bit longer effect than the other Lispro or Aspart, etc. So there is more chance of hypoglycemia with the regular insulin. Whereas better postprandial hyperglycemia is controlled by the shorter-acting insulin like Aspart, Glucasin, Lispro, because they have rapid onset of action than the regular insulin. Whereas long-acting insulin, determined large in NPH, their onset is late, 1 to 4 hours, and effective duration is almost 20 to 24 hours. And when they are used, so remember, short-acting insulin means, so insulin secretion, they occur in two phases. One of them is called basal phase. One of them is the peaks which appear after we take meal. So when there is defect in the basal phase, then there is problem in then there is fasting hyperglycemia. Basal insulin means the level which is the insulin which is secreted continuously, and that is maintaining our fasting hyperglycemia. So when there is basal insulin is defect, then there is more fasting blood glucose, and to treat this fasting blood glucose, then we have to use long-acting insulin, so that insulin secretion which is persistently low, that can be taken care of. But whereas only when there is defect only in the insulin peaks just after meals, that can be taken care of by if we give the short-acting insulin. So purpose of this short-acting and rapid-acting insulin is different. Purpose of short-acting insulin is to treat the PP postprandial blood glucose mainly, and purpose of giving long-acting insulin is to control the fasting hyperglycemia mainly, because the long-acting insulin will will correct the basal insulin secretion, whereas short-acting insulin will correct the insulin peaks, which is normally present, but in diabetic patients their peaks are absent. That's why there is more postprandial hyperglycemia after meal. So often there is fast-acting and slow-acting, long-acting and short-acting are combined. That is called insulin combinations. So potamin, Lispro, potamin, Aspart, potamin, Lispro, etc. can be combined, and that is used when there is defect in both types of blood glucose. So when there is both fasting as well as postprandial hyperglycemia, then often insulin combinations can be used, so that with less number of injections, both fasting and postprandial hyperglycemia can be corrected. So lenti-insulin, it is not used now. It is actually insulin gene preparations. I am not going into detail. This is long-acting and short-acting. 7:3 mixture is called lenti-insulin. Most important is NPH insulin. We call it as isophenol insulin also. There is a neutral potamin hecdon insulin. Potamin is added in a quantity. So the structure is same like human insulin, but potamin is added in a quantity just sufficient to complex all insulin molecules. Neither of the two is present in free form when pH is neutral. On subcutaneous injection, the complex dissociates slowly to yield an intermediate duration of action. Okay, so this is the NPH insulin. It is an intermediate or long-acting action. So subcutaneous injection, the complex dissociates slowly to yield an intermediate duration of action. So these are the insulin analogs. So analogs means they are structurally not totally similar to human insulin. So there are some amino acid modifications in this insulin structure, either to increase the duration of action or to cause more rapid onset of action. So short-acting insulin like Aspart, Lispro, Glucasin, their purpose of making this analog is to make them more, to have them so that they have more rapid onset of action and also brief duration of action. So rapid onset of action will take care of better PP hyperglycemia, and shorter duration of action of them will cause less chance of the hypoglycemia as compared to regular insulin. Regular insulin is slower onset and have some rapid longer duration of action. So slower onset will cause less chance of controlling the postprandial hyperglycemia as well as more hypoglycemia as duration of action is more. Whereas long-acting insulins, they are used to control the fasting hyperglycemia mainly. NPH insulin is also long acting, but their duration of action is less. It is almost 12 to 16 hours. That's why they need to be given twice daily. Whereas these analogs like glargine, detamil, degludec, they are longer acting, and then that can be given once daily. So short acting purpose of this short acting analog is to make the insulin more rapid onset of action and shorter duration of action, whereas long acting means to make their more longer acting, to increase the duration of action more for the long acting insulin, so that can be injected once daily. So how these analogs are formed? So analogs are modification of the native insulin can alter its pharmacokinetic profile. Insulin analog is a very important short note. We should prepare that. So modification of the native insulin can alter its pharmacokinetic profile. So how they are named? Lispro. So insulin has A chain and B chain, and B chain normally there is in 28 position there is proline, and in 29 position there is lysine. If they are reversed, so reversing amino acid 28 and 29 in the B chain, Lispro will produce Lispro. So normally there is a proline and lysine in 28 and 29. If they are reversed, then it is lysine and proline in 28 and 29, and we call it as Lispro. Or in the position B chain 28, I mentioned this is proline. If we can replace the proline with the aspartate, then aspartic acid, then it gives analog with the reduced tendencies of molecular self-association that are faster acting. So it will provide us aspart. So Lispro is just reversing the proline and lysine in 28 and 29 position, and if 28 position proline is substituted by the aspartic acid, then we call it as aspart. And gluricin is altering aspartic acid 3 at the third position of the B chain to lysine, and lysine to 29 position of the B chain to glutamic acid to produce insulin, that is called gluricin, with a more rapid onset and shorter duration action. So these are the three rapid acting analogs: Lispro, aspart, and gluricin. So in gluricin there are two modifications. In third position of the B chain there is aspartic acid to lysine, and 29 position of the B chain there is lysine to glutamic acid. Next, long acting analogs substituting glycine for asparagine. ASN is asparagine and ASP is aspartic acid. So this changing it to A chain. So previously short acting insulins are changed in the B chain, but in long acting insulin changes in A chain mainly, and substituting glycine for the asparagine in 21 position of the A chain, and lengthening of the B chain by adding arginine 31 and arginine 32 produces a derivative that is called glargine. So glargine is an analog. It contains 53 amino acids, 21 in A, 32 in B. So look carefully. Normally B chain contains 30 amino acids, but here we are adding 2 amino acids extra, arginine and 31 and 32 position, and these 2 arginine is added, and along with that there is substitution of the glycine for asparagine in 21 position of the A. That will produce glargine, the long acting insulin. It is clear at pH 4, but it has reduced solubility at the physiological pH, that is pH 7.4. That's why it is absorbed more slowly and acts over a longer period of time. And it is a peakless insulin. So long acting insulin is that will be active at the same manner throughout the day. And peakless insulin means there is no peak. That means no sudden increase in insulin level in the blood. So there is no risk of the hypoglycemia. Okay. So this is the glargine. Next is detamil, deleting threonine at the 30th position of the B chain and adding a myristoyl group to the amino acid at the 29th B chain, at the 29th position of the B chain, which is lysine. That is called that will derive as detamil. So there is deletion of the threonine and adding a myristoyl group to the amino acid at the lysine level. So in detamil, there is a number of amino acids is 50 because there is no B chain, no 30th amino acid. So detamil have 21 amino acids in A chain and 29 amino acids in the B chain. So number of amino acids is 50 in detamil, whereas number of amino acids is 53 in glargine. So it enhances the reversible binding of the albumin. It slows the transport across the vascular endothelium to tissues and provides the prolonged action. Latest analog is degludec. It is conjugated to hexadequanoic acid via gamma glutamyl spacer at the amino acid lysine at position B29. So lysine at B29, there is a addition of the hexadecanoic acid via gamma glutamyl spacer. So there is one gamma glutamyl group and it is conjugated to hexadecanoic acid and it is active at the physiological pH. So unlike glargine, which is less active at the physiological pH, degludec is active at the physiological pH, and there is formation of the multiple hexamers in the subcutaneous tissues, allows for the formation of the subcutaneous depot. There is slow insulin release from the systemic circulation. Duration of action is lasts up to 42 hours. So it is the longest acting insulin, degludec, and that can be mixed with other insulin, thereby improving the glycemic control. So as it is active in the physiological pH, other insulins like insulin aspart can be combined with insulin degludec in the same syringe, and that can be provide improved glycemic control. But this cannot be done using glargine, because in glargine it is less active with the clear at the pH 4 but less clear at the pH 7.4. So reduced solubility pH 7.4, that is absorbed more slowly and acts over a longer period of time. So glargine cannot be mixed with other insulin, but degludec can be mixed with other insulin. So these are the analogs of the insulin. A chain and B chain. A chain asparagine, it is changed to glycine in 21 position to provide glargine. 31 and 32 is added, arginine residue. Aspartic, so this is the insulin glargine. Insulin lispro, look here in green. Proline and lysine is changed to lysine and proline. Insulin glulysine, aspartic acid in 3 and position is changed to lysine, and 29 position lysine is changed to glutamine acid. Insulin aspart is just proline is replaced with aspart in the aspartic acid in the 28th position, and insulin detamine, there is deletion of the threonine and in ministerial group is added to lysine in 29 position. In degludec, in 29 position of lysine, there is a addition of the hexadecanoic acid with a gamma glutamyl spacer. So these are the, if you remember this picture, then insulin analogs will be easy to remember, and it is a very important short note. So there are short acting insulin analogs like aspart, lispro and glulysine, and long acting insulin analogs are glargine, detamine and degludec. So what are the advantages of the regular insulin over analog insulin over regular insulin? So regular insulin molecule associated with hexamer in aqueous solution at a neutral pH, and this aggregation actually slows the absorption following subcutaneous injection. So regular insulin, they are present in as hexamers when given in a neutral pH, and there is aggregation, and after that subcutaneous depot there is a slow release of this hexamer, from slow release of the monomer from the hexamer form, and there is delay in the absorption. That's why there is little bit delay in the onset of action in the regular insulin. And regular insulin is injected 30 to 45 minutes before a meal, and that can be given intravenously also. But analogs are absorbed more rapidly from the subcutaneous site than the regular insulin. So there is no hexamer formation with the analog, and there is rapid increase in the plasma insulin concentration, brief duration of action, and this rapid insulin secretion, insulin action will cause better control in the postprandial glucose, and whereas the briefer onset of briefer duration of action will cause less chance of the hypoglycemia. So better PP sugar control, less risk of hypoglycemia as duration of action is less. So these are the advantage of the analog insulin, and that can be given just 10 to 15 minutes before meal. And nowadays more ultra rapid acting short acting insulin is also derived, that can be injected even after meal because of their very rapid onset of action within 5 minutes. So analogs will be injected 15 minutes before meal, and regular insulin should be injected 30 to 45 minutes before meal. So this is up to this class. Insulin delivery system will be discussed in the next class.